Welcome everyone. Today we are going to discuss a critical, life-saving evolution in hospital medicine: the integration of rapid molecular diagnostics directly into our antimicrobial stewardship practices. Over the next few minutes, we will walk through how moving away from the multi-day waiting periods of traditional microbiology and moving towards same-day molecular precision allows us to optimize patient outcomes, reduce unnecessary broad-spectrum antibiotic exposure, and combat the growing threat of antimicrobial resistance. Let's begin by looking at the clinical reality of our most time-sensitive challenge, sepsis. To understand why we must revolutionize our diagnostic workflows, we have to look at the clock, because sepsis is an absolute medical emergency. Its initial symptoms like fever, chills, altered mental state, low blood pressure, and confusion are highly nonspecific and easily mistaken for other, less critical conditions. However, the physiological cost of any diagnostic delay is devastating. Once a patient enters septic shock, each hour of delay in administering the correct, targeted antibiotic decreases their chance of survival by 7.6% within the first 6 hours of hypotension onset. Furthermore, from the moment a patient registers in the emergency department, every single elapsed hour without appropriate therapy increases their overall odds of mortality by 9%, proving that in sepsis, time is survival. Our traditional diagnostic system struggles to meet this urgency due to a historic blood culture bottleneck. Under the conventional workflow, on day 0, we draw blood cultures and immediately start the patient on broad empiric therapy. By day 1, the laboratory flags a positive culture and provides a gram stain, giving us a general category, but not a specific target. It takes until day 2 or 3 to achieve precise pathogen identification, and day 3 or 4 to finally receive phenotypic antibiotic susceptibility results to guide a targeted treatment modification. This creates a highly dangerous 3 to 4 day blind period where patients are either undertreated with ineffective drugs or overtreated with toxic ultra-broad spectrum agents, whereas molecular diagnostics completely bypass this bottleneck by providing rapid pathogen and resistance gene detection directly on day 1 to guide same-day adjustments. The technology driving this diagnostic shift is the BioFire Film Array BCID2 panel, which runs directly on positive blood cultures to deliver comprehensive pathogen identification and resistance gene detection in approximately 1 hour. This achieves a massive 70% reduction in the time to pathogen identification, slashing the traditional median wait time of 57.4 hours down to just 17.2 hours. The panel is highly robust, targeting gram-positive bacteria like Staphylococcus aureus and Enterococcus, gram-negative pathogens like Pseudomonas aeruginosa and Enterobacterales, multiple species of yeast, and critical resistance determinants like MEK-A and C for MRSA, VAN-A and B for VRE, CTXM for ESBL-producing strains, the colistin resistance gene MCR1, and 5 key carbopentamases, including KPC, NDM, OXA48-like, VIM, and IMP. This rapid molecular data translates directly into clinical victories at the bedside by driving immediate, actionable stewardship decisions on day 1. When the BCID2 results are returned, we can immediately escalate to adequate therapy in 1/3 of patients who are on insufficient empiric coverage, such as those carrying drug-resistant gram-negatives. On the other hand, for the 1/5 of patients who are started on unnecessarily broad empiric regimens, we can safely and rapidly de-escalate, protecting their microbiomes and reducing selective pressure. A perfect example is our polymyxin-sparing pathway, where detecting a specific carbapenemase mechanism on day 1 allows us to immediately deploy highly effective, safer targeted novel agents like ceftazidime avibactam, instead of defaulting to highly nephrotoxic older agents like colistin or polymyxin B. These clinical benefits are backed by rigorous, large-scale meta-analysis data proving that integrating rapid diagnostic tests with an active antimicrobial stewardship program yields a profound survival benefit. The odds ratio for mortality is 0.72 compared to blood cultures alone, and 0.78 compared to blood cultures combined with stewardship but without rapid testing. We also see an operational benefit, with a measurable reduction in overall hospital length of stay, represented by an odds ratio of 0.91. In terms of speed, the combined approach of rapid testing and stewardship saves 29 hours in time to optimal therapy compared to blood cultures alone, 18 hours compared to blood cultures with stewardship, and 12 hours compared to rapid testing alone, demonstrating that technology must be paired with an active stewardship team to save lives. The success of this rapid syndromic model extends far beyond bloodstream infections into other critical disease states. For respiratory infections, the Respiratory 2.1 panel detects 22 viral and bacterial targets, including atypical pathogens like Mycoplasma pneumoniae, in just 45 minutes from a simple nasopharyngeal swab, though clinicians must correlate results because asymptomatic carriage is common. For central nervous system emergencies, the Meningitis and Encephalitis panel detects 14 targets from a minimal CSF sample in about 1 hour, operating at 94.2% sensitivity and 99.8% specificity. Clinically, this panel has been shown to reduce median hospital stays from 44 down to 28 hours and slash parenteral antibiotic duration from 48 down to 36 hours. Another major diagnostic breakthrough is in orthopedics, where managing suspected prosthetic joint infections has traditionally been a slow, frustrating process due to culture-negative scenarios caused by pre-administered antibiotics, which often push turnaround times to 5 or 6 weeks. The joint infection panel completely changes this paradigm by analyzing synovial fluid directly to detect gram-positive and gram-negative bacteria, yeasts, and critical resistance genes in just hours, operating with 91.7% sensitivity and 99.8% specificity. It serves as an invaluable, rapid complement to traditional testing, successfully identifying pathogenic nucleic acids even when conventional cultures completely fail to grow. To successfully roll out these rapid panels in our own institution, we must follow a structured, 4-pillar integration blueprint. First, we must establish local baselines of pathogen and antimicrobial resistance prevalence so we can measure our progress. Second, we must align our diagnostic protocols with laboratory personnel workflows, ensuring we account for laboratory staffing and schedule availability, such as 24/7 capabilities versus restricted night and weekend shifts. Third, we must define clear study parameters, using precise sample size calculations and population criteria to measure local impact. And finally, we must track the single most critical metric of clinical success, time to result, or TTR, which measures the total elapsed time from the moment a pathogen is identified in the lab to the exact moment a clinician adjusts the patient's therapy at the bedside.